Good evening to all of you. On behalf of CIPLA, I welcome you all in this exciting Brivolution web series, episode 1. So today we have a renowned Dr. Sangeeta Rawat ma'am and as a moderator, and Dr. Joy Desai sir as a speaker. So Dr. Joy Desai sir will talk about the Indian perspective of Brevarizer. Also, he will discuss about the case-based discussion in the treatment of the Brevarizer. So so Dr. Sangeeta Rawat ma'am is Dr. Sangeeta Rawat ma'am is a chief epileptologist at Comprehensive Epilepsy Care Center in KEAM Hospital and Global Hospital in Mumbai. She has done epilepsy fellowship at Melbourne, Australia in 1998, also running a highly successful epilepsy surgery program at Tertiary Referral Center. She was an ex-president of Maharashtra Association of Neurologists, and right now she is a vice president of Indian Epilepsy Association, Bombay chapter. Ma'am has published over 60 articles in national and international journals. Also, ma'am has awarded the Best Paper Award of Year 2010 for her review article in Journal of Association of Physicians. So with this introduction, a very warm welcome to you, ma'am. Now I would like to hand over to Dr. Sangeeta Rawat ma'am for the further discussion. So over to you, Dr. Sangeeta Rawat ma'am.
Good evening and welcome to all the delegates who are here. And I thank CIPLA for arranging this Brivolution web series. So today we are going to start with basic Indian perspective on Brevarizer. Now we know that any drug which first comes here and abroad, and then when it comes here, definitely our Indian population that has a different dose requirements and sometimes different side effects. So we always need to have Indian data before we get a DCGI permission. And then once we have this Indian data and the Indian case scenarios, it gives us much more confidence in what is efficacy, what is the safety of the drug, and which cases we should use. So today what I and Joy have planned is that Joy will first tell us in 15 minutes or something on the basic information on the Brevarizer, and he will also say what are the salient points which we should remember about this new drug. Followed by that, we are going to have 5 case scenarios and case discussions, which will help in actual how when we're going to use, what are going to be the problems, how are we going to use this drug, and what things we have to be careful before using these drugs, and which are the good indications. So if you have a case-based discussions, it is always better. And during this, I'll welcome anybody who wants to raise the question. Please put it in your question answer chat box, and I will definitely take up during that case discussions. For each case also, you can have a question and then just put it in the answer question box, and we will deal with that. So with this, I think let us move further. And Joy is a very well-known person in neurology as well as in epilepsy. He's director and head Department of Neurology at Jaslock Hospital Research Center in Mumbai. Now he's also consultant neurologist at Sir H.N. Reliance Hospital. He's a DNB teacher for neurology at Jaslock Hospital. He's life member of IA, IAS and IN, and also corresponding member of AES. 28 peer-reviewed articles, 6 book chapters. And we all know that he has many talks, numerous national and international. I mean, he's one of the best speaker. And I still remember when we used to be residents, and Dr. Vadia used to tell him he's a walking, talking encyclopedia. So anything you want to know, latest reference about anything, the Joy would be immediately ready with the same. So his special interests are, apart from epilepsy and neuro, he loves photography and he loves trekking. And he's a very good friend and a wonderful human being. So Joy, over to you. And he's also a very good painter. I think you should always keep looking at his WhatsApp DP where he has a new paint, which he has put. And then I think during the lockdown, he has painted many beautiful pictures, the sketches. So over to you, Joy. Yeah, and let's start with his talk first.
Thank you, Sangeeta. It's a great pleasure to be with you, and thank you for your kind words. It's the friendship of iconic people like you that makes our lives meaningful. Okay, so what we are going to do today, as Dr. Sangeeta told you, is we are going to talk about brivaracetam, and Sipla wanted to bring brivaracetam into a perspective that is of meaning to people who practice in this country. And there have been numerous webinars on brivaracetam, as you are aware so far. And I shall very quickly encapsulate in a brief manner the salient facets of the pharmacology of brivaracetam, which makes it appealing for potential application in patients who have epilepsy. And subsequent to that, we'll do some cases, and we'll hear Dr. Sangeeta share her views on how she would handle brivaracetam given those case scenarios. Okay, so what are we talking about here? Now, the reason why the neurology community and perhaps the pharmacology and the pharmaceutical industry community are excited about brivaracetam comes from the fact that in 20 years ago, when SV2A got discovered as a potentially modulable uh, target for anticonvulsant medications with the advent of levetiracetam, and when UCB developed levetiracetam as a molecule, it brought SV2A into the limelight. In fact, before this, when we talked about mechanism of action of anti-epileptic medications, we did not talk about SV2A because this was an innovative way in which levetiracetam regulated neural transmission across the synaptic cleft. So we know that SV2A regulates transmitter release at various steps. The rate of neurotransmitter uptake into the vesicle is determined by SV2A. Vesicle priming at the presynaptic membrane is determined by that. Neurotransmitter release depends on how SV2A handles as shown in this diagrammatic cartoon figure on the left, how it results in fusion with the presynaptic um, nobule of the neuron, and then results in transmission of the neurotransmitter across the synaptic cleft onto the postsynaptic membrane. Now, what is striking about brivaracetam as a molecule is that it has a far greater affinity for binding to SV2A compared to levetiracetam. So on the table, you can see that if the amount of levetiracetam required to bind and regulate SV2A is 1.6 micromoles, then it is 0.05 for SV2A. So it's almost, from what we understand from animal data, it's almost 12 times more powerful in its ability to regulate SV2A. Also, the key differences between levetiracetam and brivaracetam at a pharmacology basic bench level is that it has brivaracetam, unlike levetiracetam, does not inhibit the voltage gated calcium channel and has no inhibitory effect on AMPA receptor antagonism. And that might be an explanation for why it is perceived that brivaracetam has lesser neuropsychiatric adverse effects compared to levetiracetam. So clearly, these are some sterling qualities at a basic fundamental pharmacological level. Plus, the fascinating thing is that brivaracetam is much more lipophilic than levetiracetam, and which leads to a faster onset of action. And many of you in this audience may have heard Dr. Pavel Klein speak about the rapidity with which brivaracetam acts on its target. And he has some fascinating slides to show wherein binding of brivaracetam occurs on a ligand functional study within an hour of IV administration. So within a few minutes, it crosses the blood-brain barrier, and within an hour, you can actually image on a PET scan. You can actually image brivaracetam with an appropriate radio tracer. We all know that in the numerous pivotal trials that brivaracetam underwent, uh, in comparison to placebo for patients who had difficult to treat epilepsy, these were the results that came out. It was tried in doses of 50, 100, and 200 milligrams, and the bar charts on the left shows in differing colors. The lightest one, when the number of prior AEDs used were 1, the middle one, the mauve one, when prior ADs were numbered at between 2 and 4. And the deep maroon color bar chart shows when ADs were numbered at more than 5 in the preceding trial failures before brivaracetam was tried compared to placebo. And what the x-axis shows is the mean percentage reduction in partial onset seizure frequency from the baseline when measured at roughly about 3 months. So you can clearly see that the numbers vary from roughly between 30 and 45 to 47 in the differing doses. So if you look at the 100 milligram, then there is a 45% reduction of median frequency for those who had failed between 0 and 4 drugs. And even for those who had failed 0 to 5 drugs, the median reduction in partial onset seizures was a good 25% compared to placebo. So if one looks at a model for difficult to treat epilepsy, it had shown efficacy which was distinctive and which is a standout. And which were the drugs which these patients had failed? These are the drugs shown in the box on the right: carbamazepine, lamotrigine, and valproate, which were the concomitant medications when these patients were administered brivaracetam. I told you that now, since it has a very rapid uh, onset of action, it can be what is recommended is that one can start right away with a starting dose of brivaracetam. If the recommended dose, say in a 50 kg adult, is about 100 milligrams a day, one does not need to titrate, and one can rapidly start at the therapeutic dose. Since it has a very quick onset of action, this is useful, and it makes vulnerable patients who are vulnerable to seizures or prone to seizures have a benefit from the medication quickly. And we do know that when started at the therapeutic dose very right away from day one, there is an incidence of somnolence, fatigue, and dizziness, but it abates in time as time goes by. Having said that, if a patient is very sensitive, individual neurologists can take their own decisions in deciding whether they want to titrate over a period of week to 2 weeks, as is the norm for other anticonvulsant medications, versus titrating right away to a 100 milligram dose from day one. So that can be done individually. So looking at the Sterling profile of brivaracetam, because of its high affinity to SV2A, quick onset of action, the fact that it has much less, 1/10 cognitive side effects and psychiatric side effects, and the fact that it has very little drug-drug interaction, except perhaps for rifampicin, it appears that the population of patients wherein it may be useful may be young patients with partial onset seizures and secondary generalization, middle-aged males with localized epilepsy and a high seizure frequency, then we want to bring down the seizure frequency, and perhaps in the elderly with multiple comorbidities and concomitant medication, wherein it may be easier to produce a suppression of their high seizure frequency and at the same time not compromise cognitive dysfunction or their behavior because of underlying mild cognitive dysfunction, which is a common accompaniment in elderly patients. What about patients in India? Well, all over the country, there are large number of neurologists who participated in the Indian study, and you can see Dr. Sangeeta Rawat here, Dr. Sita Jayalakshmi, Sudhir Kothari, and my friend Rup Gursani, amongst many others, myself, Nandan Yardi, Dr. Sanjeev Sinha, and so on. So these were the Indian study. There were two pivotal phase 3 studies that were done in India. And this was a few years ago, almost 8 to 9 years ago, I think, probably a little longer than that. Um, and there was an 8-week prospective baseline period, and then there was a 12-week treatment period. And following the 12-week treatment period, many of my patients chose to continue an open label extension of the molecule when they had a good benefit from the administration of brivaracetam. The ages varied from 16 to 80 years, and out of these, little over 100 patients that the pooled data shows, 35 patients were randomized to placebo, 22, 36, and 11 to 50, 100, and 200. And the data is a little curtailed in terms of the final analysis that were available, because in some of the patients, they did not continue for the full period of time, though a larger number were actually randomized. And very clearly, the Indian patients' benefit was not very different from that of those in the Western world. And it shows here that the median percentage reduction from the baseline was roughly 46% for the 100 milligram dose and 48% for the 200 milligram dose. And the proportion of patients who had behavioral or psychiatric side effects with brivaracetam was negligible. And the key side effects that were encountered were headache and cough. So clearly, in terms of Indian data, whether our Indian patients are more susceptible, less susceptible, from whatever information we have today in terms of available objective information from the Indian pivotal studies, it looks like it's fairly similar. So in summary, the pharmacokinetic advantages of brivaracetam is that it has a better selectivity for SV2A regulation, it's highly lipophilic, it demonstrates linear and dose-dependent pharmacokinetics, there's complete absorption after oral administration with near 100% bioavailability, and there is no dosage adjustment required. This is unlike levetiracetam. For brivaracetam, there is no renal impairment associated dosage adjustment that is necessary. And like levetiracetam, it has a low potential for drug-drug interactions. And in terms of neuropsychiatric side effects, which in some subpopulations of patients with levetiracetam can be pegged at roughly between 10 and 15%, it is much, much less with brivaracetam at less than 2%. So the question that many of us are being asked by the pharmaceutical industry is that, do you think, doctor, brivaracetam will replace levetiracetam? And Bernard Steinhoff um, has written this review article about all the comparisons between levetiracetam and brivaracetam, looking at it's not a head-to-head comparison, but a meta-analysis of the randomized controlled trials. And they came up with this statement, which is very relevant here, which you can see in line 4, that levetiracetam may have a slightly higher efficacy compared to brivaracetam, despite what we know about SV2A, but perhaps a lower probability of dizziness compared to brivaracetam. So what this connotes is that in the early days, from whatever information we have, we don't really have a standout efficacy difference perception between levetiracetam and brivaracetam. The question of replacing levetiracetam can be debated. On the other side of the coin, many of you may have heard Professor Pavel Klein, and I'm sure he's going to be here sometime in future soon, talk about the fact that he thinks that the cardinal advantage of brivaracetam is the fact, which they did a post-hoc analysis in the patients that were studied in the pooled data, and he was involved in analyzing the pooled data with some of his other colleagues like Eleanor Benekem. His perception when they did a post-hoc analysis is shown in this Kaplan-Meier estimate, is that the patients who had a greater than 75% or equal to 75% reduction in their mean seizure frequency across varying doses of brivaracetam, 50, 100, and 200, most of that actually occurred in the first few days. So the connotation is that the time course for efficacy is very quick. So if you have someone who's grossly symptomatic and requires quick relief, then perhaps the benefit from brivaracetam, if he or she is going to be a responder, will be seen very quickly. And not to forget the fact that the industry is very excited about SV2A, and UCB, the company that made levetiracetam and which actually discovered and developed the brivaracetam, is also exploring other molecules of a similar kind. And there's a molecule in development called padsivonil, and you can see the structural similarities with levetiracetam. And it is again, it's supposed to be a far greater SV2A modulator in comparison to brivaracetam, and it also modulates GABA A receptors, and it's being developed in the pipeline. So the idea is that maybe 5 years, 6 years from now, we'll have other molecules of that kind with a similar mechanism of action. And the take home for many of us comes from brivaracetam long-term and real-world data. That means once the pivotal studies were over, which were for a short period of time, what happened to those patients? Many of those patients who were benefited by brivaracetam rolled over into a long-term follow-up study. And we have data of that in more than 2,186 patients of the core studies. About roughly 93% or 94% completed their core studies and continued in their long-term follow-ups. And what was recommended was an initial dose of 50 milligrams a day with a flexible dosing regimen for up to 100 milligrams a day of brivaracetam. And these were patients from Europe, North America, Asia Pacific, and Latin America. And the index for its sustained efficacy in time comes from the fact that its 1 year and 5 year retention rate was roughly 80% for 1 year and 54.4% maintained at over 8 years. So it really a good more than half of patients continued to stay on the medication in long-term follow-up, which means that they must have tolerated it well and they must have had a benefit. If one looks at the percentage reduction in their partial onset seizures, it increased over time from 43% in the first few months to roughly about 77% in the period of time, about 5 years, 58 to 60 months. And similar is the finding for a greater than 50% reduction in partial onset seizures. That means the 50% or more responder rate increased from 43% in the first few months to about 70% at 50 and 60 months. So in summary, if you look at the long-term information, not only is the efficacy sustained, but it appears that it clearly improves as time goes by. So patients are likely to do better as time goes by. And did we have any new red flags in terms of adverse effects? Then the quality of life scores were actually improved, and the adverse effects, really speaking, are restricted to headache and dizziness, which is very common. But if one looks at the neuropsychiatric adverse effects, then depression, insomnia, irritability, and anxiety is in about between 5 and 7%, whereas much more in the levetiracetam studies. And suicidal ideation and depression, much less, 1.8 and 2%. So besides this, there are some other studies which show that patients who do develop psychiatric problems with levetiracetam, when they are switched over to brivaracetam, they actually improve. So I'm going to stop here because a lot of this information has already been shared on numerous fora for brivaracetam in the past, and most of us are aware of the key tenets. And this was a kind of brief 15-17-minute revision of what we know. So really speaking, what everyone's asking is, where will we deploy brivaracetam as an anti-seizure medication? And what we'll do now is look at 4 or 5 case scenarios. And we have a very eminent neurologist and epileptologist, Dr. Sangeeta here, who has a large body of experience, more than 25 years, of dealing with patients with refractory seizures, surgical therapy, practical experience of dealing with anti-seizure medications. She's been a trialist for numerous anti-epileptic drugs, like all of us. And it will be useful to know her opinion on these cases. So the first case is a 32-year-old male who's presented with new onset seizures characterized by auditory aura, adversive head movement to the right, and loss of awareness for a few seconds. During some of these events, he progresses to secondary generalized tonic-clonic seizures. There is no family history or nor is there a history of febrile seizures in childhood. When an EEG is done, not unsurprisingly, it shows left posterior temporal sharp waves which stand out from the background, and a 3T MRI of the brain is normal. He's prescribed carbamazepine, but he develops a rash with the carbamazepine and then is switched over to levetiracetam. And that's not an uncommon scenario at all. This is very common in practice. However, his girlfriend reports a change in behavior with spells of mood swings and bouts of anger. And in one such episode, it resulted in a physical assault. So in this kind of setting, the question that I would think is worth being answered or looking for an answer would be that would one consider brivaracetam for something like this? And let us hear what Dr. Rawat has to say about that. Sangeeta, over to you.
Yeah. Thanks, Joy. I think the seizure looks like that it is probably a localization related, because even though the MRI is normal, but we are showing the There is an auditory aura showing a Hassel's gyrus origin, and then I think left full temporal sharp waves. So localization, I think then you have to think of certain drugs which already the carbamazepine has developed rash. Second is levetiracetam has given a behavioral problem. You can think of lamotrigine, but once the rash has developed with carbamazepine, the lamotrigine also has a high chances of being having a rash. So it is better to avoid that. So the options remains either a lacosamide or a brevitiracetam. That is what I'll think. And if there was a partial response to levetiracetam or a good response to levetiracetam, it is
Sangeeta, we lost you. Hello? Hello? Zishan, we seem to have lost, ma'am.
Yes, sir.
hello.
Yeah, sorry.
Can you hear me?
Yeah, we lost last couple of sentences. The mic went off.
Okay. Yeah, I think what now can you hear me?
Yes, we can hear you now.
Yeah. So I was thinking, as this is a localization related epilepsy, carbamazepine has given a rash. Lamotrigine could be one of the choice, but it is also has a high chances of giving rash again with one rash here. So the options remains a lacosamide or a brevitiracetam. If the patient has responded well to levetiracetam, the seizure control is good, then I think is an ideal candidate to switch over to brevitiracetam for the behavioral side effect. But if the good response is, the seizures are not well controlled with levetiracetam, then you might have to think of a lacosamide or a clobazam to add. That's the way I would look at it.
Fair enough. So I think, and one would be in agreement. So when one looks at a clinical scenario that is reminiscent of what we are seeing here, one of the advantages of lacosamide as a molecule is that it binds well with many of the anticonvulsant medications in terms of combination. That means it works together with other drugs. Besides that, lacosamide is known to be relatively a mood stabilizer, and it's available in an IV form for those who have frequent seizures, so it can be used in the ICU as well. And in this case, we now have a competitor for lacosamide, and brevarizer is going to be available in an IV formulation. You all heard about how quickly it acts, and because of its lipophilicity, has a very quick penetration into the brain. And yes, so here it will be a contender for the lacosamide throne in terms of. So it's useful to know that we now have numerous choices, and one can make a discriminating choice based on the patient phenotype, the adverse effects management paradigm, and the economics of what we are doing. So that's all going to factor in how we choose the anti-epileptic medication.
Yeah,
Okay.
I'll just add one thing, Joy.
Yeah.
Whenever you are going to switch only for the behavioral side, for the side effect profile, you can switch overnight. But if there is not a good control and you are changing it for the efficacy, I have had bad experience that if I change overnight, as Joy already showed a paper, that levetiracetam has a better efficacy. So the patients have thrown seizures while going over. So if you are doing it for this, then do it over 2 or 3 weeks, gradual tapering of levetiracetam, and build levetiracetam will get a full dose. So that you go do a little. So that's one thing which I have experienced.
Absolutely.
And I think
I would fully agree with you that from whatever we understand, this is the word of caution that emerges from data that we have. And per se, it makes sense that when we make a switch, we can do a graded switch. The fact that we are able to do a rapid switch and a cold turkey switch, so to speak, that means one day the patient's on levetiracetam and the next day we can switch over to brevarizer. Yes, that cold turkey may have meaning if levetiracetam has produced severe behavioral changes. And that's something to remember. And I think it's a very important and valid point. Thank you, Sangeeta, for bringing that out. Okay, let's have at case 2. So this is a female 22. She has a history of febrile seizures at 9 months of age and remains asymptomatic during childhood. Then at age 16, she develops episodic symptoms with an odd feeling in the left arm. It is followed by loss of awareness. And she has sometimes persistent speech during her loss of awareness without contextual meaning. And at times, this is accompanied by a right-sided throbbing headache. Initially, she was chosen to be on topiramate because she had both seizures and seizure-associated ipsilateral headaches. But by age 19, she has an increasing frequency of events because of late nights at college. She's studying architecture, has various assignments to complete, and has a tough time getting them done. She admits to having mood swings and bouts of feeling low with impairment of working abilities at times. And one could conjecture here or speculate that this could be at times related to the fact that she's not getting enough sleep, when we know that sleep deprivation can also produce mood changes, amongst other things. And that could be a mood point for lifestyle modulation. Having said that, what would one do here? And Sangeeta, it's all yours, just to how you would handle this.
Yeah. Yeah, hi Joy. Now you need to remember here that she's a young female of 22, and we always have to be careful whenever we are choosing drug for women. This girl probably has temporal lobe seizures, or mostly a right temporal, because she has a persistent speech during the episodes. But she probably also has an associated migraine, because she also has either it is a post-ictal headache, or whether she may having a different
Migraines too.
isolated, yeah, migraine also. And we have a bilateral correlation with migraine and epilepsy. There's always increased chances of epilepsy in migraine patients, and migraine patients having epilepsy patients having migraine more often. So the drug of choice remains here. I think you should go for the primary drug like carbamazepine or oxcarbamazepine, because they're a good mood stabilizer, or a lamotrigine, because here brevitiracetam would have be one of the choice, but we do not have a data on the pregnancy yet. So still it is in the C category. So it is advisable that we hold on for the brev in such female patients who are likely to get married anytime after 22 is a good age to get married. Better to use the primary drugs like carbamazepine, lamotrigine, or levetiracetam. Now, levetiracetam, because she has a lot of mood swings and all, I would prefer that we go to either a lamotrigine or a oxcarb, which also has a mood stabilizing effect. And they will also control this temporal lobe epilepsy, because it's like a focal epilepsy, which is a good drug. That's what.
Needless to say, none of us are thinking about using divalproex, right?
Yes, I am not thinking of that, definitely.
Right. So, no, I think it's important for everyone, and there are many physicians, I think, in the audience. So, it's important to understand that many of these subtle but distinctive nuances of what a medication could do to differing biological processes that can affect a woman in a childbearing age profile is a determinant of how we choose anticonvulsant medications. And therefore, it's an integrated process of making choices rather than leaning on any one drug or group of medications because of underlying bias. Great, wonderful. Um, let's look at a third case scenario. So this is case 3. This is an elderly person. This is a male who's 74. He's presented to the emergency medical service with episodes of irrelevant speech and a very peculiarly noticeable lip smacking movement of the mouth, which is associated with arrest of movements during any task. So he's doing something, freezes a bit, makes lip smacking movements, and seems to talk gibberish during the event. He's hypertensive, diabetic, has coronary artery disease, all of which are treated and controlled. He admits to snoring during sleep, like many of us, and occasionally experiences daytime drowsiness. And this is a facet that is sometimes not questioned, but in our hospital because of my interest in sleep. We always take a sleep story. He says my memory is also weak, and I need to write to-do lists to get my all my jobs done. So he has early cognitive dysfunction, and his MRI of the brain, not surprisingly, is reported as age-related atrophy with grade 2 periventricular leukoariosis. And the EEG shows bilateral temporal slowing, with the right side being more disturbed than the left. And he's prescribed lamotrigine by us, uh, since since it is an appropriate medication. But as you all know, we always titrate lamotrigine gradually, and it was a very gradual titration. And during the titration process, he has frequent clusters of these episodes. And Sangeeta, we are waiting with bated breath to hear what you would do now.
no, no past history of similar attacks anytime. Joy?
He's not had adulthood seizures. He's not had childhood seizures.
Okay.
And I was thinking when I actually saw him that these are late onset seizures, conjunctive
Yeah,
with
late
his
onset.
cognitive, yeah, conjunctive with
Right.
his cognitive
So we
dysfunction.
need to look at the etiology or some other, so like you need to see for any limbic encephalitis or any paraneoplastic or autoimmune, which is
Right.
in fashion now, the autoimmune. So that we
Yeah.
need to check because if something like that is there, just either before adding the any anticonvulsant, they will be controlled much better by the immunosuppressant.
Yeah.
So
So
if that we need
that's a
to,
very phenomenal understanding that people who have escalating seizures and have seemingly normal looking MRI, as here, in the sense that the MRI is innocuous, it shows some atrophy, doesn't show any
yeah,
striking signal abnormalities in the mesial temporal lobe. So we know that people like Ruben Kuznecki have demonstrated that even in such individuals, if one did a PET scan, for example, and the
PET
PET
scan,
shows
absolutely.
asymmetric, uh, very high uptake in the mesial temporal regions, then it would warrant a very diligent search for autoantibodies to neuronal epitopes, either cellular or extra, and consider the fact that immunosuppression might be a potential mode of regulating the seizures. So you're quite right. One would do a more diligent search. And if that is
Yeah.
negative, then what?
If that is negative, then again, I think you only tried one drug, lamotrigine. So we can still try, since he's come in EMS, we'll have to give with the injectable or a fast-acting drug. So
Right.
here the option remains again levetiracetam lacosamide as an injectable, or if you want an oral fast-acting, then the Brev is a thing which we can think like giving by RT and it will have a quick action. That's what I think Pavel Klein had said that
Yeah.
it has a very, I mean, though I myself have not used in the EMS the oral Brev, but that remains an option. But otherwise, I think I would be comfortable giving injectable lacosamide also, to control because I've seen in elderly it gives very good seizure control.
Yes, I would agree.
So yeah.
Yeah.
Only thing is like we have to just check on cardiac status and ECG and all. I
So
mean,
even
but it's
yeah.
I mean I don't know. Have you seen this
Yeah.
lacosamide and
So
ECG
I just
changes?
yeah, that's a very good thing that you have brought up, Sangeeta. And I think it's a very important and valid point that you're asking, that how often should a concerned neurologist worry about cardiac conduction defects in patients who are being
Yeah.
treated with lacosamide? I, for one, have been, like you, using lacosamide fairly frequently in
Hmm.
both clinical OPD practice as well as in the EMS and in the ICU. And I have to date not encountered someone who's developed bradycardia or an AV
Absolutely.
conductional abnormality. Having said
Same
that,
experience.
the published literature seems to imply that if one is going to use lacosamide in a dose greater than 400 milligrams a day in a recipient who is elderly, then it would make sense to look a little more diligently at
Hmm.
their QT interval, their AV nodal transmission signs on the electrocardiogram, and make sure that they don't run into a conduction problem. So while many physicians would worry about it, I think the worry is for a very small, restricted
Yeah.
segment of elderly people. But that's an important point of consideration.
Yeah. So I think then again, so I mean that's the options I will look at it. Then Brev remains on orally to be given. I mean, I've not used, parampanel in the EMS much, though there are cases. I mean, Manjari was saying that they have been using in all status epilepticus the parampanel, and she's finding it excellent.
Yes.
Thing, but I don't have an experience. So
Yeah.
I
So
mean,
even about perampanel, I think perampanel is a very good point to discuss. And perampanel is, by virtue of its very unique AMPA blocking mode of action, is an effective anticonvulsant. And you actually see data. The data looks very powerful. And I did do perampanel studies too when perampanel did pivotal studies in India for ASI. And the experiential thing that came about in practice is the fact that though we use perampanel in 2 weekly titrations of 2 milligrams, many of my patients who had difficult to treat epilepsy did develop behavioral changes and either aggression,
yes,
suicidal ideation at roughly between 4 and 6 milligrams. And I, for one, have now started doing a titration very, very gradually. So in my difficult to treat epilepsy, I think it's useful, but I would titrate at 2 milligrams every month. And I don't do 2 weekly titrations anymore. I have started doing monthly titrations. So you give 2 milligrams, wait for a month, then go from 2 to 4, wait for a month, and then go from 4 to 6. And that uh, clearly decreases the risk of the potential behavioral changes. Now, in someone who has frequent seizures like here,
yeah,
because you need a slow titration, just like lamotrigine, it would be difficult to deploy
difficult to try.
perampanel here.
Really.
Yeah, so one would
So
need something that is quick, which is safe, which can be given IV potentially. That's also useful, or which acts quickly when given orally. Yeah, you were saying something. Sorry, I didn't mean to.
yeah, I was just asking your opinion. I mean, what do you think of efficacy wise between Brev and Parampanel? What's your experience, personal experience?
I don't know. I think both are good, and I personally do think perampanel has a role, and but perampanel is like a
I, I
temper
think it's all
tantrum
or none
prone child.
somewhere.
It's a very it's just like a child with temper tantrums. You have to handle it carefully. I think it's effective. It does its scholastics well, but you have to handle it correctly because it's very fragile. I have
Hmm.
had some very difficult reviews from patients when I've used it in bitemporal epilepsies or in those who have post-encephalitic epilepsy, and almost invariably they have come back and said, "Doctor, we want something else
So that's
because
what
of
when I
behavioral
feel like
changes."
there is a set of population where we just can't use it even though we have tried.
Yes, but if you
So
don't
that
have that, if you don't have that,
yeah.
then say if the patient has seizures from a dysplastic cortex in the posterior temporal or parieto-occipital junction of the zone,
Then they do well, I think.
um,
Yeah.
then it's not such a big thing, and it is an effective drug, so one could use it, but with a graded titration in conjunction with other drugs which have a different mechanism of action. I
Hmm.
don't like combining levetiracetam or brivaracetam with perampanel. I would rather, unless pushed into a corner, I would rather
Hmm.
combine, say, perampanel in with lamotrigine and maybe low dose valproate in
Yeah, a
someone with that kind
sodium
of problem.
channel or a
Yeah,
multi-mechanism.
so you have differing mechanisms of action, and you try
Hmm.
and bring out the best in every drug uh, in terms of its anti-seizure potential.
Right.
Okay, can we go to the next
Yeah.
case? We've got 2 more.
Yeah, yeah. I think we can. Yeah.
Super. Great. So what about case 4? This is a 17-year-old, again, very common clinical scenario, presents with morning predisposition for generalized tonic-clonic seizures associated with being clumsy and messy at the breakfast table. And when that happens at the breakfast table or in the bath in the early morning hours, we know that this is often an index of
Right. Yeah.
myoclonus. Birth and childhood history are normal, known to have a volatile temper and is prone to tantrums when his wishes are thwarted, like many adolescent children, especially in nuclear families. And in the last 6 months, he has gained 7 kilograms of weight because he's a cricket fan, like many in the audience, and watches matches and IPOs and one-day internationals late into the night with ice cream binging during the long sessions. His EEG shows very signature changes of juvenile myoclonic epilepsy. There are brief, fragmented, numerous polyspike and wave bisynchronous discharges with polyspikes and an aftercoming slow wave at 3.5 hertz. And an MRI of the brain is innocuous and a 3T-MR looks relatively normal. And now here is a scenario which is very, very common. And we know that
Yeah.
there are a restricted number of drugs that are efficacious in JME. And what would you do here, Sangeeta?
Yeah, I mean, first I need to talk to him and ask him how, I mean, whether can he control his weight, whether he can go down in his, ice cream binge eating, because for him, ideal drug would be valproate.
Oh, absolutely. Yeah.
Absolutely, ideal drug would be valproate, and it will also take care of his temper tantrums, because I mean, volatile temper, because it has a mood stabilizer effect. But in case if he can't do, and I mean, I'll also tell him to do regular exercise, start gymming, and go for, if not gym, at least go for a long walk, which can take care of his weight. And then I think then remains if not working out, then remains either a levetiracetam or a brevitiracetam. Now, again, with temper tantrums, may go over to brevitiracetam, but we still have to have enough literature on the JME and Brev. We have enough with the Lev and JME, but secondary generalized seizures, Brev is very good. And with JME is also, it should be good because it is in the same way as the levetiracetam. I have had a couple of patients, I mean, I think 4 or 5 patients on JME where I've added Rev. But what's your take on this, Joy,
Yeah.
your experience?
Yeah, I don't know. I have a few important thoughts on a case like this. What it tells us is that this is a very typical vignette, and I have had discussions of this kind of observations with Dr. Roop Gursani, who also thinks similarly about JME. And if you look at even the original paper that Dieter Jans wrote, and I had a chance to meet Dieter Jans some years ago in The Hague in the Netherlands when we had a 3-day meeting on JME, and it was a most fantastic meeting. And Dieter Jans was there, the guest of honor, and many people spoke about research. And Dieter Jans has shown in his original article when he described JME that many of these children who have JME have a behavioral prototype which is very as if it is they have some degree of frontal lobe dysfunction, and his perception is that these children who have JME have behavioral problems which are difficult to handle because they have a degree of frontal lobe dysfunction. John
Yeah, even
Duncan.
the neuropsych also shows in some of these patients this
So
frontal dysfunction.
John Duncan's group from Queen Square actually in the 2000s had a large number of studies, some done by their German research fellows, showing that if you do quantitative MRIs in these individuals, then one can even demonstrate microdysplasia in the frontal lobes. So behavior here is probably driven by, partly driven by the biology of what they have. And I would entirely agree with you that valproate would be a very great choice. It is very important in our clinic to counsel patients, find the time to talk to them, explain to them why even a simple thing as 2 scoops of ice cream, 300 calories consumed at 11 p.m. can result in immense weight gain because of its effects on leptin and ghrelin. And the very fact that uh, weight control is a lifestyle phenomenon, and if one exercises, if one is diligent about dietary regulation and not eating at the wrong time, and avoiding consumption of high calorie food after 8 p.m., that itself can change their weight profile. And low dose valproate does not result in weight gain. We all know that valproate is associated with weight gain, but the weight gain of valproate experientially is a problem at 1 gram and above. But if you're using say 200
Yeah.
milligrams and 100 milligrams or 500 milligrams a day or 600 milligrams a day, weight gain is not an issue for most people. So even this weight gain adverse effect of valproate is often represented with too much fear. One can understand it a little better with a closer look. And yes, valproate would be a good choice. And in those where epilepsy seizures are fragile in JME, I often use with valproate, very low dose valproate, say 200 twice a day, which is a very, very low dose, and slowly add in a modest amount of lamotrigine, gradually
Yeah.
bringing it up to 100 milligrams twice a day. And we have a large number of patients in my epilepsy clinic at Just Look, where we have patients on lamotrigine and valproate as a combination. And my average dose is 100 milligrams BD of lamotrigine with a very gradual titration, and just low dose valproate 200 BD, and patients are seizure free for long periods of time. So
Yeah.
that's
I think
one
it's a
thing.
good synergistic combination which you can always
Oh,
think of the
absolutely. So
JME.
that's one
Yeah.
thing, good thing to remember. And yes, levetiracetam can be used in patients with JB, but in those who have behavioral problems, I'm a little hesitant in deploying levetiracetam. And brivaracetam, from its pharmacology, is possibly a candidate, but I don't have any experience yet, so I don't know what to say.
That's what we still have to wait for the more data on
Yeah,
this, I think.
yeah. Plus, I don't have any personal experience, so I have not used it. Great. Thank you. So let's move to
The last case, I
the
think.
last case. Yes.
Yeah.
All right. So we'll do case 5. So this is a 56-year-old man who has a history of generalized tonic-clonic seizures of recent onset. He's assessed at a tertiary hospital, and as is usually the norm, he undergoes a CT scan from the EMS because the physician asked for it, and the CT reveals 2 right-sided hyperietal calcific cystic lesions. The EEG is normal, as is often the case in parietal epilepsy. The systemic evaluation is normal. He has screening X-rays of the calves done, which don't show calcifications of cysticercosis in the muscle. He's prescribed oxcarbazepine, but he comes back after a few weeks with seizures, and it's found that he incidentally has hyponatremia, which then is attributable to oxcarb. So it is substituted by lacosamide. On lacosamide, he remains seizure-free, and he's doing well, but he has breakthrough seizures for 2 reasons. He is erratic in his compliance with lacosamide, and he consumes large quantities of alcohol regularly. And after a weekend alcohol binge, he remains stuporous, does not take his anti-seizure medication for 2 days till Monday, and he's brought to the EMS in status epilepticus. So seizures continue despite lorazepam, thiamine, magnesium, intravenous lacosamide, correction of ionized calcium, levetiracetam and valproate therapy is administered rapidly, and nothing seems to work because he continues to seize. And perampanel is added by the Riles tube, as is often the case, but his episodic seizures continue. And I think, Sangeeta, here we should be discussing how to deal with status. This is a very typical scenario, anti-seizure medication withdrawal associated status. In a background of alcoholism, you must be seeing a lot of patients like this in KEM. And it would be nice to know how you would deal with this.
Yeah, so one thing is this alcohol binge, and then forgetting the drugs for 2 days over the weekend. Then they Monday morning they come up with the status, which is quite common. I think one is that often they do get control well with loading dose of the whichever drug they have missed. All like lacosamide or what it was just there. Now, one drug which you have not tried here is the phenytoin.
Yes. It
Yes.
happens sometimes. Sometimes we miss the drug that we used for so many years.
Yes, yes. And nowadays, I think it happens more often because the intensivists are always happy with levetiracetam pushing. They don't consider them. So I think that one drug which you can think of adding if it's not controlled. And one thing which I've learned over the time is always look for a venous sinus thrombosis in these alcoholics, even if they had a calcific cysty, but it's probably not enhancing. So it's an old thing. And if it has come with a new, I mean, onset of seizures, you have to rule out another cause, because alcoholic can have a subdurals, they can have,
Oh
they
yes,
might have fallen, they have a venous sinus thrombosis. So even though it's, you know what is the cause and is a known epileptic, but still, if they've come up with this thing, always try and
yes.
investigate again with the imaging
Yeah,
to check for
that's
that.
a very, very
Yeah,
important point. I think alcohol dehydrates. Alcohol
yeah,
can induce changes in the clotting cascade. And yes, it would be important to do fresh imaging and make sure we are
mm,
dealing with an additional acquired potentially epileptogenic substrate.
absolutely. So after that, this remains in the, I think phenytoin is one which you can think of, and then I don't know, rest all you have used except the carbamazepine, which is an oral drug which it takes
Yeah.
time to act. So then remains, if we get the injectable brevitiracetam, maybe we can try. But already levetiracetam has been tried. But then there are, I think Pavel was saying, even if the levetiracetam has not acted, he has some cases where injectable brev has acted because it's supposed to be a higher efficacy. But that we
Right.
need to still wait and see. I think that's the, and if not, then finally we'll have to go over to the higher,
Anesthesia. So
anesthesia and
tell me,
things like
when
that.
you Sangeeta, in KEM, what is the
Hmm.
trend when you use anesthetic agents? How do you use the
See,
four
I've been trying
conjugates?
to push more for ketamine, but people, I mean, I don't know, somehow there is a lot of resistance for ketamine coming from my intensivist, so they still want to give propofol first. There are cases they go second, is if propofol doesn't, I mean, starts having side effects and alcohol, I mean, the hypotension starts, then they think of. So but now I've been trying to push, if there is an hypertension, I think try first ketamine and see what is
Right.
the effect. Yeah.
I would entirely agree. So I'll share with you my kind of experience and thoughts on status. In when I started practice in 2000, when at Jaslok, uh, it was a disaster because the traditional pentobarbital, when I used pentobarbital in the ICU, in my first 4 or 5 patients developed severe hypertension, myocardial
Yeah.
failure, and they actually died. And I just could not handle the fact that I was failing in controlling seizures and had mortality in my first 5 patients with status. And then and there was a time when Simon Chauveau was here, and of course I had worked with him in UK in the past. So Simon Chauvin's, and we went to few of those status epilepticus meetings that are held in the colloquia that are held in London and in Austria, in Innsbruck. And Simon Chauvin's regime was that you use high dose midazolam. So for a long period of time, almost 7, 8 years, I used to use high doses of midazolam up to 1 to 2 milligram per kilogram per hour. So, which you can imagine that in a 50 kg adult, you would be using midazolam between 50 and 100 milligrams per hour. And that's a large amount of midazolam. Midazolam is effective in controlling seizures, but in a person of this kind, phenotype, someone who's had a history of alcoholism, we do not know his liver reserve, to give a benzodiazepine for a long period of time, getting him off the ventilator would be difficult. Hypertension is a very big limiting factor. And in my experience also, and from literature, the risk of breakthrough seizures, when you, even after achieving suppression of seizures for 48 hours, when you withdraw midazolam, the risk of breakthrough seizures is almost 30-40%. So here, because of his alcoholism and maybe unknown pancreatic reserve, I would hesitate to use propofol. And I agree with you. I use a large amount of ketamine now. I
Ketamine,
think
yeah.
with
We are also trying to push
oh
ketamine
yes,
more and
oh yes,
more.
and that there is enough information. I think we have enough data, and I have enough experience now with ketamine to be very confident. And it's not difficult at all to use ketamine. It's safe. We can use it for 24 hours, 48 hours, 72 hours. And once you're on 100 milligrams an hour, it has good success. You can use between 100 to 200 milligrams an hour of ketamine
Yeah.
and control seizures and manage suppression of the EEG, enough to produce burst suppression and try and control seizures. I had a patient with who was in his 70s with polycythemia, who like this was not an alcoholic though, but he had NORS, new onset refractory status, and he got controlled actually with ketamine, and finally went home and it's recovered and done very well. Now from his 7 anti-epileptics, we brought it down to 2. So individually, yes, these are changing times, and I think these changing times help us make discriminant decision-making choices when choosing an anticonvulsant. We need to understand the molecule, and I think it's good that we are here today on a platform, however late in the evening, trying to understand a new molecule, because the more we know it, the more we may be comfortable in handling it in real life, in situations where every factor is going to matter.
Yeah, I think thanks, Joy. Really, it was a good discussion. Good you thought of having case discussions. Preeti, do we have some time to take some questions?
Yeah, so we have about
from the audience.
5 take-home messages before we
Yes,
can do the
ma'am.
questions. So in summary, I think the take-home
Yeah,
I
sure.
wanted people to know
Okay.
is that it's a new anti-seizure medication with pharmacological features that appear to impart it with stellar potential for use in clinical practice. While we know that trial data is restricted to a modest benefit within a very strictly defined population of difficult to control epilepsy, we know from retention rates and from the percentage reduction of partial seizures in the long-term follow-up studies that over time it seems to get better. So real-world data is therefore encouraging, and it has an appealing retention rate. We know that its application in clinical practice will be individually variable, as numerous options are available for partial onset seizures with relatively well-tolerated medications. So knowing our drugs is going to be very useful, and its place in epilepsy management is going to be determined by the actual realization of its potential in the next few years. And maybe 4 or 5 years and down the line, we will be in a much better position to designate its position in the umbrella of drugs that we have. So thank you for your attention, and thank you, Sipla, for asking me to be here today in your first Brivolution. And with that, I will stop sharing slides, and we could go back
Yeah.
to.
Yeah, Joy, you still have to answer the questions from audience, okay?
Yes. So
Yes,
no,
yes.
not me. I think both
So
of us have to answer. So I'm not going to answer them by myself.
both of us, yeah,
You know?
okay. Yes, both of us, right. So I think the first question is from Dr. Pramod Donde.
Yeah.
And he's asked, what about sodium channel blocking property of Brev? Is it significant and does it hamper its use in IgE?
I don't think so. That's a good question, Pramod. And from the pharmacological literature, the sodium channel modulatory effect is negligible. So I think I don't think that should be a cause of concern for treating IgEs, but we will know in time. But to my knowledge, it's not an important parameter.
Yeah, I think it's negligible. It's not there. Yeah. I think Dr. Girdhar Mukherjee has asked that Rev and Lev are similar, then why is the psychiatric side effect less with but I think this Dr. Joy has already covered in his talk that a specific
It's the
reason
AMPA.
is in the mechanism of action that
Yeah. So that's the
AMPA.
thought.
It
Yeah.
is very selective for SV2A. And it doesn't bind to AMPA as well as calcium channels. So that is the reason why it is thought that it does not give rise to psychiatric side effects. Okay, the third question is from Dr. Sanjeev Sauji. What is the effect as a mood stabilizer? Any evidence on that?
We don't know. I am not
We
aware
don't
of.
have a literature on us.
I don't have access to that, so I don't know the answer to that. But having that question is relevant.
I think published as a mood stabilizer. Yeah.
But what happens in
I think we don't
anticonvulsant
have.
medication development is that this mood stabilizer thing comes from the industry push, because the industry clearly identifies the market of psychiatry as a very important market. And I was quite amazed in the early days when I saw prescriptions of clobazam by my psychiatric colleagues, and I actually asked Dr. Amit Desai, who's a good friend at Jaslok, as to Amit, what's clobazam doing in the prescription? There you are. Clobazam was developed, and in fact, it got approval as an anti-anxiety medication. And I wouldn't be surprised if brivaracetam gets undergoes clinical trials as a mood stabilizer, but time will tell us.
Okay. So the next question is from Dr. Vasudeva. And he says, I think we have already discussed role of Brave in a female with JME who has a psychiatric side effects and then a reproductive age.
I think you've said most of the things that.
Yeah, we need to wait till we get the data. Yeah. We still don't have, and we have to wait for that.
Agreed.
Okay, this next question is Anne Value Morgan. And is it brevacetatum can be given in less than 16 years since DCGS only approved above 16? I think in US it is above 4.
Yes, not in India.
In India it is not in India yet. Okay. Then Dr. D'Souza has asked, if we are to switch from Lev to Brev, how does one go about it?
Yeah, Sangeeta, you want to take that? You are aware of it. You know the ratio 1:10, 1:15.
Yeah. So there are two. I think one we already said cold turkey switch, where you want to switch overnight. So whenever you are doing it, if patient is well controlled and you are doing only for the seizure, side effect profile, you can do a cold turkey 1:10. So if you have a 500 of levetiracetam, you give 50 milligram of levetiracetam. Okay.
Right.
That is one switch. And other is the same dose, the ratio remains same. But if there is uncontrolled seizures and you want to switch from Lev to Brev, always go over 2 or 3 weeks. Then, the breakthrough seizure chances are less. So that you need to keep in mind. Anything else you want to add, Joy?
Yeah, I think that's the preferred switch is 1:10.
Yeah. Okay, there's a question from Dr. Amit Kumar, and it says, kindly comment on enzyme-inducing action of Brev and possible drug interactions.
Right. So there is some literature on this, and I think there are 2 or 3. Though we like to think that there is very little drug-drug interaction, I think there is an interaction profile with rifampicin, and there is an interaction profile both with phenytoin and with carbamazepine. I am not sure about oxcarbazepine, but I know for sure that I had a patient whom Roop and I were looking after together. The patient used to sometimes go to Hinduja and sometimes come to Jaslok. And he was on very large doses of oxcarb with difficult to treat epilepsy. And the family had chosen not to have surgery for the dysplastic lesion. And when I put him on brivaracetam, he had very severe ataxia and diplopia too. So I wasn't sure. The father was convinced that this was all because I had used a large amount of brivaracetam in conjunction with oxcarb. So I'm not sure about this because we don't have literature about oxcarb, but I have one patient which made me a little worried that maybe we've got to be a little cautious because it's a new drug and we don't know how individual patients will react. But with these two, with sodium and phenytoin sodium, and with carbamazepine, I think there is a drop in levels of phenytoin and carbamazepine. Is Zishan here? Is he with us?
Yeah, Zishan.
Yes, sir.
Yeah, so Zishan, I think is there in literature, right? So these two?
I think so, sir.
Okay. There's a question about dose adjustment required in hepatic patients from Dr. Nikit Shah.
Yes. So that's again, I think many in the audience are aware of that. So I don't know how hepatic failure is graded into mild, moderate, and severe, but the pharmacology literature on brivaracetam says clearly that in severe liver failure, one has to reduce the dose. So yes. I would assume that if there are lab parameters in terms of SGPT, SGOT, and acute fulminant hepatic failure. So if a patient has acute fulminant hepatic failure, then the dose of brivaracetam has to be lowered. One thing is fairly categorically clear, that one does not need to alter the dosage of brivaracetam for renal failure, unlike
renal failure.
leviracetam.
Yeah. Dr. Agarwal, Akash Agarwal has asked Brevepsi as first option in focal seizure. What's your take on that?
I mean, I
Monotherapy.
don't know. I'm not in this game of deciding who's the first guy and who's the best wife. I think all wives are good. Many of these have their own merit. So I don't think I would try and make broad and sweeping statements about first choice, second
Yeah.
choice. I think these are all choices,
So
and
I
no
think these are personal
choices go
choices
wrong.
which you
They are
think.
very personal choices, and everyone can
Yeah.
have a leaning towards one. The whole idea of
And it all
understanding a
depends how
molecule.
much comfort you develop while using
Oh,
this. And
absolutely.
first,
So
you have to develop comfort while add-on. And once you're comfortable with add-on, then I think you can think of using as monotherapy. You
I
don't,
wouldn't
I mean,
promote it as a first choice. I don't think so.
yeah,
I
we
think
don't have, I mean, till now, all of us are using as add-on. And Dr. Bhavani has asked, if we experience LEV is safe in pregnancy, what about Brev? I have seen no studies and no safe. Yeah, we already covered
yeah,
that, I
that's true.
think.
That's true. We
Doctor,
don't know that. So we asked this question to
yeah,
Pavel Klein actually when
right.
we met him in one of his talks, and we asked him this question, and he said that he was not aware of registry data. When we asked this specific question, Dr. Klein replied that in his awareness, neither of the two registries, the European and the North American, have just now available data on brivaracetam.
That's what you're
Enough.
saying. UCB has somehow not focused on pregnancy registry, and he was surprised with that. So
And I
I'm
think the
also,
current norm is to have at least 5-year data, right? Even after delivery.
yeah,
So for cognition.
right. Okay, so last two questions. I think Dr. Gupta, Uday Gupta has asked, in which epilepsy brevitiracetam can be used as first-line therapy and or is it add-on drug? I think we already covered this. What other drugs can be added to Brev for maximal efficacy? So he's asking
Yeah,
for the combination with Brev.
fair enough. So I think in which seizures you might want to choose brivaracetam, maybe looking at the fact that it has a very quick mode of action in someone who has seizure clusters
Acute
and who
clusters.
has aggressive frequent seizures of new onset. And yes, you could use brivaracetam because of its potential for quick efficacy within the first few days, and the fact that its penetration is very fast. So yes, there could be a potential there. Where would you combine it? It always makes sense to when you combine medications, to use medications with an alternative mode of action. So just like we did for levetiracetam, where I like combining levetiracetam with lacosamide. I would think that in practice in future, I would not hesitate to perhaps combine brivaracetam with lacosamide. I would not hesitate to
Yeah.
combine brivaracetam with, say, valproate, which has multimodal modes of action. And
Nowadays, I also see Joy many prescription on Brev and Ficompa together. I don't know. I have
yeah,
not used like this
well, so
together, but I've seen many prescriptions.
yes, so I have one patient. I have a case that I showed in the epilepsy masterclass. This was a patient with a Lennox-Gastaut-like syndrome, nearing adulthood, in Gujarat from Ahmedabad, who were very difficult to treat seizures with pleomorphic seizures, myoclonus, absences, falls, atonic, and generalized. And I then used valproate, lamotrigine, brivaracetam, and perampanel. So yes, I think we'll all have to walk around these new drugs and figure out how to use them. There's so much that we don't know.
Okay, so the last question is from Dr. Vasudeva again, and he's saying whether Brev can replace Lev in reproductive age groups, which I think is the same thing in JME or other genetic myoclonic epilepsies. So, I think in MTS in females in reproductive age who have leukopenia with carbamazepine, oxcarb, then can we use Brev? I think we can't say yes, you can, but you can take your choice, taking patient into confidence, because till now the recommendation has not come for the pregnancy. I think Zishan, any other questions? I think
No, ma'am. That's all.
No, ma'am.
Yeah. Okay, so good, Joy. I think we really enjoyed this. I think good you put the cases. I think that was very exciting, and I was not bored being only as a moderator.
Yeah, that's the reason. When they told me that you were there, I said we should do this differently and not do some silly didactic talk.
Yeah.
Anyway,
that
we have
was a
heard
good
enough
idea.
of those on
Let's-
Brevarizer, so
Yeah, lots of ad word we have finished.
right.
Okay, thank you, Priti, and I really thank Cipla for making this happen, and I think we really enjoyed this evening, both of, and I hope the audience has also enjoyed the cases and the discussions and questions.
Thank you,
And we
everybody.
are also going to have, I think, future web series. I think Preeti will
Yeah.
tell about the further web series.
Professor
Yeah.
Felix Roseno is going to be speaking next, I think, next time.
Right. Yeah.
Okay, yeah. Thank you so much, ma'am and sir. So I think that was a very wonderful and insightful discussion. So I would also like to inform the audience regarding the upcoming webinar on the international clinician perspective on Brevarizer. On with this international speaker, Dr. Felix, along with Dr. Sangeeta Rawat ma'am. Also, I would like to extend my thanks to Dr. Sangeeta Rawat ma'am and Dr. Joy Desai sir for a wonderful and insightful discussion and presentation. I would also like to thank the audience for their time and participation. Thank you so much.
All right, thank you.
Yeah, and
Thank
there were
you so
good
much.
questions also from audience, I think.